last 2 days, we've heard practitioners share their experiences on different approaches they've used to claim accountability for sexual and reproductive health and rights. We've heard talk about different types of evidence, different types of knowledge, different things we want to know, and what counts as evidence. We've also heard about lots of new challenges that are occurring that we're working in, both in national and global contexts, and also about new opportunities and collaborations and thinking. And one thing I've heard over the last few days is the importance of resilience and how people from different parts of the world and beyond are pushing boundaries in the most challenging of circumstances.
There's so many issues that have come up over the past several days that show that a classic state-centered understanding of accountability doesn't always work. It assumes that people with citizenship or other legal status live in a country which has obligations that citizens can demand through democratic processes at the local or the national level. This claims making often presupposes that the people making the claims have access to information or can produce information that they then leverage in making demands. And as we've heard over the past few days, this paradigm is often not the reality, especially for some of the most marginalized and for issues that relate to sexual and reproductive health and rights. First, some people don't have legal status, as we've heard throughout the week. Some are denied the citizenship that is their due because of discriminatory law and practice, so they're actively excluded. Others are migrants or refugees with fewer legal rights or exist in a legal limbo with acute sexual and reproductive health needs. This can play out in particular ways for sexual and reproductive health and rights, where LGBT practices may be criminalized, abortion may be criminalized, and certain services such as comprehensive sex education, for example, may not be legally mandated. Some governments don't believe that people should be making demands on the state, irrespective of what that demand is about. So we can argue that people are born with human rights, but the reality is that many live in countries where it's dangerous to make such claims.
I'm so glad to be here sharing women's reproductive health rights in China. And first of all, what I want to talk about is policy directive. As one of the most famous policies in China, as you may know, one-child policy. It has implemented for 35 years. It was first designed to control the size of the population last century. However, it did control the size, however, during this period, because it has become history until 2016. It is not until 2016 each couple has the right to have no more than 2 children. And during these 35 years, because the implementation of the family plan is a key indicator to assess political performance for some local officers if they want to get promotion. So during this period, there were millions of violent incidents happened. Millions of women were forced to give abortion, forced to place IUD bodies without no knowledge of when will they put it out, because normally we know IUD only put in our body for 5 or 10 years, but most of Chinese women, they place the IUD for more than 30 or 50 years, and that is really difficult for them to get rid of this later. And what's more, also the first to give ligation surgery. Yeah, so many violence happens, and I have one more extreme example. It is happens in last century, 1991 in Shandong province, one of the provinces in China. There's an incident called 100 days childless, which means that there will be no children in 100 days, no matter if it is your first baby or second baby, no matter how many months you have get pregnancy, all of the women are forced to get abortion at that time. That's really ridiculous. And even to 2012, there was a woman with 7 months pregnancy was forced to give abortion. So this kind of news is really so sad to hear so many news. And but now the one-child policy has become history. And recently, as we know, China's fertility rates has been declining. So now the whole nation actually is really actively encouraging fertility, which may lead to another extreme problem that women may be forced to give babies.
So I'm going to share with you this slide, which is talking about how a woman who is empowered with information about being HIV positive and having access to SRH can look like. That is Esnat in the center, in the red dress. And this woman became pregnant at an early age. That's when she discovered that she was HIV positive. By then, she did not know how to go about her rights as a positive woman or a child. So she lost her first child because she had no proper access to SRH services, and she could not speak for herself. So now we see the process that she had gone through after being empowered with knowledge and information about her status and her rights to SRH services in Zambia. After joining the Treatment Advocacy and Literacy campaign, I gathered a lot of knowledge about myself and about other women in the community. And I was able to decide when to have a child. My next child was very much self because I was empowered with the advocacy and the rights that I need. I had to decide when, that is the first photo, when to have a child and how to have it. The second photo is the how. You know, in Zambia and Africa at large, you're not given an opportunity as a positive woman as to how you're going to have your child. When we were using the option A+, it was mandatory that you go through cesarean section because there were not so many options for you to prevent your child. Now, after the coming on board of the option B, you had at least an option to decide whether you go for C-section or normal delivery and what type of family planning you had to take. But that information was not trickled down to the community. But since I knew what I was supposed to do, I went for the C-section and I demanded that it will be done on me, though it was not free, but expensive. These are decisions that you cannot make if you don't have the power to pay for your services. Otherwise, women in the communities, they cannot access certain services due to lack of information. There was a study that we did where women, when they go to the clinic, they were not given any other family planning method except the barrier method, which is the condom. And as a woman, it's really difficult for us to negotiate for safer sex using a condom. So this was a result of women becoming pregnant when they did not decide to have a child. So we educated them on their rights to demand for another option or several options be offered to them so that they can prevent being pregnant when they don't want to have a child.
I would like to share about the private doctors' unethical practices which is going in the field all the time. So in Karnataka, we have a civil society forum working on intensively on the right to health and protecting women rights. So in the 2014, there was one incident happened in one district called Chikmagaluru. There was a unwanted hysterectomies was conducted by the private doctors, private hospitals and doctors. So this was very closely without knowing the women, the marginalized community women, also the below 30 years of the women, without knowing them, they have conducted several hysterectomies in the one district. It was founded by the media actually. The women who have post-operative compliance came and they have came to the PSC, then they have identified that and they have explored a larger operation, media operation, and this is explored actually. After the incident explored in the media and other places, So we have conducted a intensive fact-finding mission. So this fact-finding was not done one day or 2 days. It was taken little long. Almost 2 months we have traveled in the villages and the tandas. Very closely we have interviewed with the women and we have identified the scandal what is going on. So we have found that 707 women have underwent the unwanted hysterectomies. It means overall 98% of the hysterectomy is conducted by the private hospitals. 61 private hospitals actually. Among them, 61 private hospitals, just 4 hospitals have accounted the 344 of all hysterectomies. It means the private hospital doctors have not maintained the register also. Only 4 hospitals have maintained register, the 334 hysterectomies. And the age group of the women is very interesting that below 35 years, 51% of the women are below 35 years. And 22.5% of the women are below 30 years. This is the age group of the women who have underwent the hysterectomies. And we have taken an in-depth interview with the 82 women who have among the 707 hysterectomies. So all 800 women had a hysterectomy done in the private hospital. The women spend on average 26,500 rupees to 2 lakh rupees. This is all from their own pocket money, out of pocket money. There is no any insurance have covered actually.
My presentation is about, I'm going to talk about our subnational and national engagement, how we have managed to influence the communities to access abortion and post-abortion in general sexual reproductive health services. And of course, under the community empowerment program, we have a theory of change, as you can all see, whereby we believe that once the communities are empowered, they can manage to make dialogues by themselves and formulate some actions, which leads to policy level advocacy. And of course, with all this, we have improved access of the uptake of the sexual reproductive health services. We have used an approach called the community scorecard. And with this approach, this is a participatory approach that empowers the communities to at least demand for efficient, satisfying services at their local levels. And as you can see in the picture, here are the women and the men that are trying to discuss the issues in their communities. We don't take the issues there. We give them a chance to identify the issues that they have in their communities, and then through using the scorecard, they score them, like there's a scoreboard which runs from 1 to 5. Of course, 1 being very bad and 5 being very good. So once an issue is scored, is ranked, like, let me say, many people have said, yes, this is an issue that we want, and we want to advocate, we want to get solutions for, let's say, teenage pregnancies, and maybe 10 people have voted on such an issue, then that one is ranked and prioritized number 1. And after they have all discussed this, we put the men together, the health workers alone, and the women, so that some of the decisions are not biased, you know how this be. And then they come back in plenary and then discuss and present to each other the issues that they have identified, and then they form action plans, of which as HEPS, we come back and keep monitoring the progress of these issues. But with the same process, we look at the input tracking, whereby we monitor the services that are available on facility level. not only the services, we monitor the stock levels of the commodities and the medicines that are there, and we keep doing this in a period, let's say, of 4 to 6 months, monitoring the progress. Is this available? Are there any stockouts? Why are there stockouts? What do we need to do? And we inform the district level up to the national level with this. Of course, the community empowerment program informs the national level for us to get the policy advocacy, the policy makers to act. That is briefly about the approach that we use.
I will talk in Hindi. And
Yes,
Okay.
I will translate, yeah. So Mahin will be speaking about an initiative that was carried out in the state of Madhya Pradesh. It's called the Sajedar initiative. Sajedar means partners. So it was partnership between men and women, and men and the community and the state. So there was partnership at various levels, therefore the name Sajedar. And it is from 2 districts, Morena and Sindhi. And the idea was to see how maternal health can be improved through also involving men and boys. Yeah, the idea was that very often maternal health is seen as something that that concerns only women, and the burden of improving maternal health is also taken on by women. And the idea was that since men are also involved in the process, how can we make them more accountable, and what does that lead to in terms of outcomes? So the two areas are a little bit in contrast. The area of Morena was one which was very feudal and therefore has a kind of masculinity which is very violent and hegemonic. There's a lot of control of women over there. But also the access to services is more, it's a more mainstreamed area. Whereas in Sindhi, which is the tribal area, women have more autonomy, but it's an area which is very isolated, and so access to services there is very poor. The poverty and lack of awareness there was also much more pronounced than it was in Morena. Yeah, I think even that is quite clear on the slide. There were 2 parts of the intervention. The first was to influence men as individuals, to get them to reflect on their own socialization and how they can change to become more sensitive partners and fathers. And the other was to influence them as responsible citizens and motivate them to take collective action to further accountability. So what he said is that the intervention worked through these groups of men which were organized with systematic capacity building, and the men's groups then started to do participatory assessments of what are the gender conditions in their particular villages related to social norms, for example, child marriage or exchange of dowry or dropout of girls from school, and they also did an assessment of what are the kinds of health services available. And based on that assessment, they created 2 kinds of charters. One was the public charter, which is the demands that they as a group had from the state, and the other was the social charter, which is the commitments that the community would make to address harmful social norms. And both these charters were what they campaigned with. So there were campaigns which were addressing the accountability of the community towards women, but also campaigns which were calling out the state for the lack of services. And then along with that, they did a community inquiry into maternal health services. So you can see the scorecard which was developed with that, and then that was used to do public dialogues with the health system.
The impact of the private sector as it regards to sexual reproductive health. That's one. Then 2, for Caroline, please. We have high rates of what's it called now? Teenagers' pregnancy. I'm just thinking, actually, what absolutely is the cause? Is it that there is high rate of rape, or is it that there is high rate of, I don't know, get that fact? Thank you.
The kind of community that we work in, you find that most of these, we try to ignore the bit of poverty. because I mean it's everywhere in most cases, and now we try to look for ways instead to prevent, despite the poverty that is going on, by giving these people the information that they need. Because someone comes and they are walking to school and they are told, hey, come, I'll buy you, what language can I use that we can all understand? Maybe a soda and maybe a piece of cake. I will ride you to school on my motorbike. Then in the evening, you'll come and then I will take you home. In the course of doing that, they don't end up home but in their beds. And it has been happening, and that's how it has been, it has been happening in these rural areas, whereby you find someone is just given a soda and end up in someone's bedroom. So it's not about rape. Yes, rape also contributes, but it's not the only one. Yeah.